Good evening, everyone. My name's Hannah, and this evening I'm going to present to you the emergence of lifestyle medicine. So we're going to look at the history of disease and key historical figures, the epidemiological transition, the emergence of lifestyle medicine, key pioneers and evidence within lifestyle medicine, and finally, the role and the future of lifestyle medicine in healthcare. So we're going to go back to the Middle Ages, where a lot of civilization died from infectious and acute conditions. And as Darren Mott had stated, if they actually kept a death record during that period, they would it would actually reveal that most people died of acute conditions such as the bubonic plague, smallpox, and cholera. And so there are some key historical figures that we're going to talk about shortly that had made amazing discoveries, and they've all made such amazing contributions to health and prevention of disease in their era. So we're going to start with my personal favorite, Florence Nightingale, who was a nurse serving in the Crimean War. And she observed that about 10 times more soldiers would die from diseases such as cholera than they would from actual warfare. And so her and her team of nurses went to work and improved the unsanitary conditions. And this ultimately reduced the death rates from these infectious diseases. So she developed some foundational views about sanitation that encouraged a worldwide healthcare reform, and she would go on to be the founder of modern nursing. So we're going to look at Ignaz next, excuse my pronunciation, and he was known as the father of infection control, and he observed in his hospital in Vienna, when a doctor delivered a baby there were higher higher rates of mothers dying from a post-delivery infection compared to a midwife delivering. And he discovered the midwives had different practices to the doctors. And basically the doctors were going from doing post-mortem exams to delivering babies. And there was no hand hygiene in between. So Ignaz made it a practice within his hospital for doctors to wash their hands in between tasks and patients. And therefore that dramatically reduced the death rates of these mothers. So another key person is John Snow, and he was an epidemiologist, in London. And at the time they believed cholera was spread by miasma or a bad air that people breathe in, and he didn't believe that. He thought that was not quite right. So he did a range of research and found that cholera was spread by contaminated water. And he was well known for removing the handle from the Broad Street pump, which he believed to be the source of the outbreak. And it did. It resulted in the disappearance of cholera from that area. We then go on to Louis Pasteur, and he was curious about this germ theory and if there was a potential to be able to kill these germs and bugs. And he went on to develop pasteurization, and he discovered that by boiling things or increasing the temperature of things, he could actually kill these germs and these bugs. And then finally, we're going to Alexander Fleming, and he incidentally discovered penicillin. So apparently he was known to be quite a messy person, and he'd left food scraps on his desk where he'd also left petri dishes full of staph. And he went away for a few days and came back and discovered that the scraps had gone on to the petri dishes, and that the staph had died. And what had happened was the fungal mold from the leftover food had actually killed the staph samples. So therefore, that was the discovery of penicillin, which has gone on to cure millions and millions of people from infectious diseases. So we're going to go on to look at the epidemiological transition. And the epidemiological transition describes changing patterns of the population age distributions, mortality, fertility, life expectancy, and causes of death. So the definition of health and healthcare has developed over time, and that's particularly in the 1950s, post-penicillin and post-World War II, or during World War II. And from my nursing experience, we are taught the definition of health is from the World Health Organization, and that is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So here is a table which shows 5 stages of the epidemiological transition. So stage 1 is that infectious disease era in history, which we spoke about earlier, where lots of people are dying from infectious diseases and accidents. Birth and death rates are very high and life expectancy is very, very low. And in stage 2, this was the onset of that medical revolution. Due to those key pioneers that we again mentioned just before, we see a significant reduction in infectious diseases. There's improved sanitation, improved nutrition, improved medicine. And then in stage 3, countries are becoming more and more developed and populations are living longer. And there's this emergence of these chronic diseases such as heart disease, cancer, diabetes, and obesity. And then in stage 4, these countries are becoming significantly developed with excellent healthcare systems, but there's still this rising epidemic of chronic diseases. And in stage 5, which is still not clear how this is going to emerge, but it is emerging with COVID-19. And this is due to globalization because we are more connected than ever. Yeah, so we'll move on from there. So this is just a little slide about chronic diseases and goes into diabetes, heart disease, and cancer. And these are Australian statistics. And the one that surprised me the most was 2/3 of Australian adults are now overweight or obese. And 2/3 is such a high proportion of our population, and something clearly needs to be done. So we're looking at the emergence of lifestyle medicine. And as I learned a few weeks ago, there's a lot of different definitions of lifestyle medicine because it's such an emerging area, which is quite exciting. So for the definition that I've chosen is from Professor Egger and his colleagues, and it goes: the application of environmental, behavioural, medical and motivational principles to the management, including self-care and self-management, of lifestyle-related health problems in a clinical and or public setting. And then just to the right here, I've got these 6 pillars of lifestyle medicine. And there is more pillars, but for the process of this presentation, I'm going to do the 6. So I've got nutrition, exercise, the absence of tobacco and alcohol, stress management, sleep, and healthy relationships. So we've got our key pioneers in lifestyle medicine. We've got Dean Ornish, who in 1990 led a randomized control trial study revealing that atherosclerosis, which is the disease in your coronary arteries, could be reversed through rigorous lifestyle change. Then we go on to Nathan Pritikin, who was diagnosed with coronary artery disease in his early 40s, and he adopted this plant-based diet with regular exercise, which is quite unheard of in his time period. And he ultimately reversed his coronary artery disease with these lifestyle changes. And that was seen even when they did an autopsy of Mr. Pritikin once he passed away, and they looked at his coronary arteries and there was no evidence of any coronary artery disease, which is incredible. And then we go on to Caldwell Esselstyn, and he assigned 19 patients with inoperable coronary artery disease and tasked them with this intense lifestyle change. And what happened was 12 years later, those who stuck to the program that he had set had not died or experienced another cardiac event, which is absolutely surprising. And then finally, we've got Hans Diel, and he created the Coronary Health Improvement Program, also known as CHIP program. And that is actually the most highly recognized community-based lifestyle medicine intervention. And I know for a fact within my immediate group of friends that a few of them have done this CHIP program and have seen amazing results. So I'm just going to look into the evidence of lifestyle medicine. So my first study is looking at low-risk diet and lifestyle habits in the primary prevention of myocardial infarction in men. And this study comprised of 45 to 79-year-old men who had no previous medical history of diabetes, hypertension, high cholesterol, and they were followed through to 2009. And basically it looked at these low-risk lifestyle practices such as being physically active, no smoking, alcohol in moderation, and a healthy diet and a healthy body weight. And what it revealed in the end was that almost 4 of 5 myocardial infarctions in men may be preventable with these combined behavior and lifestyle changes, which again is the evidence is there that this is the way that we should be going. The next study I have is a randomized control trial, and it looks at the reduction in the incidence of type 2 diabetes with lifestyle intervention or metformin. And this study looked at 3,234 pre-diabetic patients. And they were popped into 3 groups. So one of them was a placebo group, one of them was given metformin, and one of them was given the lifestyle modification. And what it revealed was in pre-diabetic patients, the lifestyle intervention reduced the incidence of type 2 diabetes by 58%, and metformin reduced the incidence by 31%. And clearly the most successful intervention was the lifestyle modification. And then lastly, we've got percutaneous coronary angioplasty compared with exercise training in patients with stable coronary artery disease. And basically what this is they had a 2-month program of regular exercise in patients with stable coronary artery disease. And this resulted in the absence of another or cardiac event and reduced the incidence of rehospitalization and recatheterization with, going back in and having a look and doing an angiogram. So I'm just going to move on to the role of the current role of lifestyle medicine in healthcare. And from my perspective, it's got this multidisciplinary aspect, with our dietitians and physiotherapists, with our physiotherapy. And there's this element of lifestyle medicine. However, Professor Egger and colleagues state in their textbook that there is actually no current single discipline trained to practice preventative and therapeutic lifestyle changes. Because, our doctors are trained to diagnose and treat, but they don't necessarily have the time to guide patients through these lifestyle changes. And, as nurses, we are trained to care and manage patients, but we aren't really taught specific knowledge about lifestyle changes. And I attest to that. About 8 out of 10 patients, I work in a cardiac cath lab and coronary care unit, and patients ask me post their intervention, hey, what can I do to, be healthier and prevent this from occurring again? And I can give them the basics, but I can't give them the specifics. And same with our dietitians, physiotherapists, and psychologists. So there's definitely a need there. And then I also see it in our cardiac rehab. So I know at the SAN, all our patients that have an intervention such as a stent are referred onto cardiac rehab. And what this is a 4 to 8 week program where they do regular exercises, training programs. They're taught about specific nutrition, and they're also taught about, mental health and the effect of stress, which is huge. But this is only offered to patients that have had an intervention. There's a lot of patients that we do angiograms on that have minor or moderate disease that doesn't require intervention yet. And really, we should be intersecting at that point too, because, these patients are put on some sort of statin, which is fine, but they're not told anything else, how to, potentially reduce their coronary artery disease or keep it at bay. So, you know, I believe that needs to be a more primary approach rather than, you know, this secondary approach. So I'll move on to our final, and so the future of lifestyle medicine and healthcare. Now, I believe that the lifestyle medicine needs to be this first-line therapy, this primary prevention, and healthcare systems and society needs to focus on proactive prevention, not wait for these symptoms to occur, and, you know, not wait for the hypertension, the shortness of breath, the angina, etc. And, you know, as Professor Egger and his colleagues state, the location and the delivery of these lifestyle medicines should, once they're established, shift away from hospitals and clinics and go to actually where the individuals spend most of their time, such as work or school. And this should create, you know, a societal change, and this will help to create a culture of where health and lifestyle choices are emphasized and are valued. And, you know, if we don't do anything about this, soon we as health professionals will be unable to keep up with the current need for treatment and care of these chronic diseases. And again, as Professor Egger and colleagues mentioned, and in fact, this is a direct quote, to treat 21st century problems with 20th century reactionary approach to healthcare would require an unachievable number of physicians, both from an infrastructure and economic perspective. So there does need to be a change in our current model. And as on another quote that I like up here is, the healthcare system of the future must evolve. And it does, it needs to evolve into such a system in order to better address the current state and future trajectory of chronic diseases around the world. So lifestyle medicine is this interdisciplinary whole system approach focusing on prevention and reversal of chronic diseases through the modification of environmental, social, and behavioral drivers. The field of lifestyle medicine that I believe aims to assist individuals and communities to adopt and to sustain these healthy lifestyle behaviors. Lifestyle medicine is a very, as you can see by the evidence, a very powerful yet often underutilized tool. And with the rising epidemic of chronic diseases, as we're seeing, something has to change to the in the current model that we're using in healthcare. Hence, lifestyle medicine must be the future of healthcare. So thank you for listening, and I hope you learned something new.